Okay, my name is Pat Alexander. I was pink yesterday, in case you've forgotten that this is me, but it looked like a bloodbath in the shower last night when I washed it all out. Oh, it was such fun. Okay, well, I think you've all done pretty well to get here quite this early. We did wait a few minutes for it to fill up a bit, but yeah, I think this is okay. And I picked a picture which I thought was pretty important about networking, because isn't that what we've all missed? You do Zoom, you do Teams, Fate, whatever. This is what it's about, isn't it? I think it's terribly important that we don't forget where we come from and what we do. Housekeeping. No fire alarms today, so if one goes, it's for real. I know that you're not supposed to collect anything, but have your phone tucked in handy somewhere, because you would not survive without your phone. So make sure you have your phone with you. Okay. They're going to give out some prizes later. Best workshop, best launch pad. So please vote. Go onto your app, your conference app, click on the survey, and the ratings are 1 to 5. I'll be honest, I haven't looked yet, so I'm not sure whether 5 is good or bad, but make sure you do check, because it's devastating, as you probably all know, to get the wrong score because somebody got it wrong. And you know that they got it wrong. You know they didn't really mean you were that bad. You're going to get a certificate of attendance, but it's going to be emailed to you, so there won't be that dreadful Scrabble at the end. And of course, if you wanted to slip out early, it's always hard to find yours. But it's not a good idea to slip out early, because if you attend the last session, you get put in a draw and you may get a free attendance at next year's conference. Oh, so it is. Well, I'm sure that the last session, it will be incredibly worth staying for anyway, but it's going to be really worth staying for. I'm interested in the new board members' notice, because I didn't think we'd voted on that yet. I thought they were still the exec. That is just me being nitpicking. Okay, so would you like to go to a meeting at lunchtime, 12:15, in the Paris suite? So if you are on the exec committee stroke board of directors, do what you're told. So what have we done in our conference so far? I'm ashamed to say I didn't dance last night. I'm sure you will miss that. But I decided to go back to my room and make sure that the pink really did come out, because I didn't think it was very professional to be doing this stuff today. Pink hair. It's not me, really, is it? But I can see that from these workshops I attended, and looking through and talking to other people who attended others, some people have used their spare time to develop some very useful tools, and some of them are still developing them, and some assessment templates were shown, and I think that's a brilliant idea that they've been able to use that where we're doing different work. I'm sure most of us have had to change the way we work or work in a different way. And I think another thing we learned from the number of sessions, proning is an essential skill to teach now, isn't it? And I have to here give some kind of thanks to my friend Mary Muir, who gave me an excellent coaching in proning some years ago, which I have always been able to use. So thank you to Mary. I know she's not here. Somebody please tell her. Good news. The things we've all been waiting for, HOP7, and of course the long-awaited paediatric update. It really did go through some difficult times, as many of us did. As far as I'm aware, the paediatric update book is here at 10 o'clock today, arriving sometime this morning, please God. So please put your hands together and say a quiet prayer, because we worked very hard and machines breaking down at the last minute, so it couldn't all be stuck together. So possibly, I don't think this is true, you might get a whole lot of pages that haven't been stuck together. just bear with us. But certainly they're either on their way or, like HOP7, we know, at the end of November. And finally, what else have I learned? Well, I think if anything that we take away from this conference should be Mike Frey's warning. By the way, Mike, I know you're here. I am still going to tell you, I still don't understand vectors. I spent a lot of time in the classroom with you when I went from being a tutor on the course to being a delegate on the course, And everybody assumed I knew everything about biomechanics. This is not true. And I looked very intelligent during the session. But later on, I did tell Mike at another conference in Australia, I still didn't understand it, and he announced it to the whole world. Pat tells me she doesn't understand vectors. I'm going to get you, Frey, for that. I really am. But we have to learn to handle technology. We've all had to do that, haven't we? I'm sure most of us had to do a lot of strange things this last year and a half, but before it handles us. So I think as manual handling advisors, that is pretty important. This is my own announcement. I have purchased, through a very helpful, kind friend, a very small prize. I'm having a mini competition because I'm thinking, what else can I say this time of the morning? So I'm announcing a competition. We have a gaggle of geese. We have, is it a murder of crows? We have a murmuration of starlings. I want to know what collective noun would suit us. Whether you think we're manual handling advisors or back care advisors or whatever, I would like to have something that fits us all. That's going to be quite difficult. But if you could give your answers in to the MB desk, there will be a little prize. I will announce it now. What's our last? We're not doing the last session. We're doing the one before last, aren't we? Our session. So I will have the answer by then. And it will be a very small prize. So it will be interesting to know what noun we choose, wouldn't it? Okay, let's start the real stuff. I would like to introduce Philippa Fitzmaurice. She's a Senior Health and Safety Manager at United Lincolnshire Hospitals. She's been a commissioned officer in Princess Mary's Royal Air Force Nursing Service. She's a chartered member, as mine, of IOSH, and she's in her 3rd year. I'm very sorry, I have put that in with a spelling mistake. I apologise. She probably is yearning for it. But she's in her 3rd year studying for a doctorate at Nottingham Trent University. So I'd like you to put your hands together, please, for Philippa.
This opportunity to share with you some of my experiences during this doctoral journey. First of all, I would like to perhaps give you a title for this presentation. It's Framing the Message, Healthcare Support Workers' Experiences of Patient Handling Training Using Visual Research Methods. This thesis is presented as part of a partial fulfilment towards the requirements of my doctorate, and I'm undertaking it at Nottingham Trent University. And as Pat has quite rightly said, I'm yearning for its completion with my viva due in the next 4 weeks. And after that, hopefully, my qualification. So I welcome any questions at the end of the session. I am also making available this presentation for you with speaker notes and also a selective reference of key areas that I think you might be interested within my research. So to start with, as you will see, this presentation is very visual and there is an importance to that. And I want to give you the purpose of this study. And really it was to observe the personal experiences of healthcare support workers during manual handling education training session whilst attending an induction programme. The purpose of the study was to provide a voice for such experiences to be heard and to inform future training in safely assisting and moving people. The research methodology is a qualitative and interpretive study using a hermeneutic, phenomenological research methodology that incorporates a visual, critical methodological framework for data collection and analysis. The focus of using visual research methods provided the participants with the opportunity to interpret their training experiences through visual and written text. These methods were approved by the organisation's governance department and were both accessible and agreeable for healthcare support workers taking part in this study. My approach to this inquiry is from an outsider looking in, a researching professional with a nursing background. This approach will enable me to establish the foundations for partnership with the participants of my study. My interest in this particular field of inquiry has developed over many years, and recognising with the emergence of an increasing use of technology to replace many of the manual handling physical tasks once performed by nurses, there is a requirement to acknowledge the specialist need for training. I therefore situated myself as a participant, professional researcher. I share with the participants the experiences of people handling within an acute healthcare environment. However, I do not claim an identical experience to the roles being undertaken in the present climate of the NHS. I'm also mindful that a professional culture of working practices within the NHS can exist amongst some clinical specialities, which could have a bearing on those participating. Topics of conversation. I have used the COVID pandemic word there, and I think from the start of my research, looking at various elements that have incorporated into it, it has been an ongoing learning experience. And it would be mindful of me not to include this, particularly in the relation to the impact on conventional classroom teaching. And I attended a session yesterday that was given in one of the supernumerary sessions about the social distancing requirements now that we are having to understand about when we're delivering training, and the pressures put upon us with new and inductees into our organisation. By raising the profile of this particular area and the importance of equipment safety, incidents and recognition are preventable where patient harm and staff harm can occur. Part of this process of the research is to undertake a literature review. I've enjoyed this experience. I have looked at many studies going back some 20, 30 years in nursing, and also the widest perspective of training and understanding how this element can be looked at, identifying potential gaps in research, and appreciating also the constant scrutiny to deliver patient care safely, whilst balancing the act of financial performance in the NHS. And this, and will continue, remain a significant concern to many in governance. I will take you back a few years. Florence Nightingale. It is known that Florence Nightingale was deeply ambivalent about the line along which training should be developed, and she recognised that the success might only be achieved after years of trial and experiment, and indeed my some 30+ years I am still learning. At the heart of the debate was whether training should be theory or practice-based. This aspiration is also acknowledged by authors like Tyndall and Bark, who identified Florence Nightingale as an early pioneer in laying the groundwork for competency, evidence-based medicine, and best practical clinical guidelines. A published article in the Nursing Education Today by Taylor in 2010 provides an informative history on the state of UK nurse education post-implementation of Project 2000. And many of you in the audience today will recall this massive leap forward in nurse education. Drawing upon the issues identified, the authors debated many concerns which I believe are still relevant, including developed practice, knowledge, skills amongst students. Pre-registered education was overly theoretical, and the lack of support by mentorship programs in ward environments. And some of these are ringing true today. The conclusions at that time drawn were pointing towards nurses not being educated to being flexible, visionary, and prepared to take risks, that embraced a modernised career of nursing, cognizant of its services to the practice of nursing. No presentation goes without looking at regulatory frameworks. And this particular slide shows the balance that we as educationalists, trainers, NHS senior leads have to acknowledge, the balance of achieving statutory and regulatory legislation, the requirements placed upon us by the health and social care providers, the role of the Health and Safety Executive, the governing body, the enforcement powers that these regulators have, and failure causes breaches, and those breaches, as you know, and being on the receiving end perhaps, of inspections, can lead to a closure of service, financial penalties, and formation of costs if found guilty. All this evidence I've looked at within my research. And what I'd like to take to the next slide is perhaps how we can learn from the incidents and also reflect upon this. And in my study, I have looked at several elements. The engagement of teams is crucial to how we learn from incidents. And my research has identified numerous case studies where private nursing homes have described events, certainly from the consequences of breaches of health and safety, the inadequate training, the inappropriate use of lifting equipment, combined with failures to communicate information. And I do feel that COVID has to look at how we address communication with the wearing of PPE. Are we understanding that communication when it's shared with us, particularly in intensive care? I've also looked at research not only within the understanding of incidents, but human factors. And I know that that is very current and should be considered along lots of informative technology that is now being used. We need to have a just and learning culture. And when I've looked at my research, I've not just gone to the UK, but I've explored other countries. And India, interestingly, have produced a more recent research, COSY and others, in 2020, looking at staff working in an intensive care unit adjoined to A&E departments. And ironically, within the research, the focus by their governing bodies in terms of safety has largely been around construction sites. So when the authors went to look at A&E departments, they did an observational study and found that many of the staff did not communicate their transfers. There was a failure to actually empathise with the patients, to communicate the needs of what they were trying to achieve, and more importantly, understanding the basics of using that equipment safely. A very interesting article, which I've put as one of my references within my notes for you. So what does it bring to the table, this information? Well, it brings discussion, And I think that's a key element that Pat has alluded to, and many of the speakers. The discussion provides conversation, and it was my intention to show through this research the importance of manual handling. And you're starting to see now the flavour and the research methodology that I'm using from this one particular photograph here. So, what am I using as part of my research? The visual materials you will see are the research tools being used. What I wanted to achieve was to provide a system of learning through the use of tools that the healthcare support workers could actually interact with, they could understand, and then impart their experiences through these mediums. The findings from this study, I hope, would have a bearing not only on future training, but open up that dialogue, particularly with healthcare support workers, who we know that perform the largest proportion of our manual handling techniques within the ward and departments. And I also wanted to actually put forward recommendations. A research with its value has recommendations that can enhance the learning for future discussion around research. A conceptual framework is used by many researchees. It gathers the pointing, the reference from which to go forward. And I've used an adapted tool by Bloomberg and Volpe. This tool allowed me to look at several key elements. The lived experience. What actually was I trying to achieve through our healthcare support workers training? I wanted to hear their voice. I wanted to understand whether they enjoyed that training. I also wanted to actually look at see if there was a problem that needed to be addressed. And in that, is it part of creating an enabling environment for learning? And discussions during this conference, I've heard that again, the learning environment is a concern. We are receiving cutbacks in the organisation where a practical room of this size is being transformed into ICT or other departments squashed into a space. So are we actually now reducing that opportunity to create an enabling environment for learning? The hospital itself, I wanted to look at as part of that conceptual framework. I wanted to look within the hospital, patient safety and associated risks. And I wanted to bring the link in that conceptual framework to the use of mechanical lifting equipment by healthcare staff. I also wanted to look within my research technique a choice of how these visual materials could be used within health and social care. And most importantly, in the protection of my participants, the ethical considerations and the safeguards to protect them during my study. The conceptual framework itself then pulls in a lot of the actual descriptors you've heard through this conference. I was looking at the complexity of technology and recognising that there are many new initiatives out in the fields in terms of bed frames, overhead gantries, raise and recliner chairs. But with all that, there is the inherent risk of patient safety incidents. And you notice I have focused on patient safety, but I'm also mindful that we still have to consider staff safety in all of this. The training style, and actually I was quite empowered by the session yesterday by Pam, who actually said we need to think about the way we deliver our training and some of the key words that we're using. And whether actually that forms part of that policy and how often that training's taking place. And I suppose the end goal on the left-hand side of your screen is the reduction in litigation costs. And actually going forward, can we reduce it to 0 incidents? So the framework formed my research questions. In order to meet the aims and objectives of the study, the following research questions were developed. What are the experiences of healthcare support workers involved in a practical session on an induction manual handling training programme? And the second part to this is, what are the healthcare support workers' perceptions and understanding of the terms risk and patient safety when using lifting devices? The methodology. So I took an ontological position using an interpretive social constructive paradigm. It's a qualitative study as opposed to quantitative. It reflects the meaning of a lived experience through new interpretations. I adopted a purposeful sampling procedure to understand the context and circumstances of my participants involved in the study. My study involved using a means to actually interact and engage with my participants. As you can see there, it is visual research. It also included photo production and photo feedback. So my study involved 11 healthcare support workers attending an induction programme. The reason for choosing these staff is that they account for one of the largest group of unregistered healthcare workers in the NHS who perform primary key nursing tasks such as assisting patient moving and handling. It was a purposeful sampling procedure, and therefore the criteria was as follows. All participants must be healthcare support workers. All participants must have completed a recruitment process and enrolled on the Trust's induction programme. For practical training and safety reasons, the ratio of trainer to student was set at 1 trainer to 8 participants. And for safety reasons, all participants would be required to acknowledge their fitness to undertake practical training and inform the trainers prior to the session of any health concerns. I also included in this criteria various counselling and support mechanisms for the participants, and it formed a dynamic risk assessment process which could reflect the changing needs of the research study. The training programme must take place, and this was fundamental in my criteria for the procedure, in a classroom environment attached to the Trust, where the research and the ethical permissions were granted. 11, as I've said before, healthcare support workers met the criteria. 10 were female and 1 was a male. There were 3 health and safety trainers assigned to delivering the training programme, and the trainers within the context of this study delivered routinely the induction programme, and it was planned as part of the yearly training schedule. The trainers delivered were qualified in patient handling and had valid competency certificates to the equipment products used. So as you can see from this research slide showing an old-fashioned disposable camera. So this evoked many responses at my primary meet and greet of my participants. One being, I've not seen this before. And 2, how do I use it? So why did I choose a disposable camera? Well, much research in visual imagery has been undertaken, both in health and social care, but also in the field of sociology. And I recognised that I needed to be able to give my participants the freedom to use that camera without the constraints of possibly data protection, but also technology, and actually have what was a unique insight into a photograph in real time that could be produced and was produced by a product provider, Boots, and then shared with the participants the following day. So what does visual imagery evoke? And I think that's key to my choice. It evokes information, the feelings and memories at that point in time. But when we reflect upon an image, as you can see in that particular slide, it brings back perhaps a time and a space and a recall that is important. And it gave the opportunity for my participants to look at it in the setting, in the context of that particular training. So this particular slide shows here how it was representative. And I wanted to give the opportunity of my participants to share their feelings during that training session. So I used a very basic equipment map. I purchased from a provider, stationery provider, rolls of wallpaper. I then gave them pens, and I then opened to them their images, which they had produced the previous day. The excitement was overpowering to me. They opened up their packages, they looked at their photos, they then shared that discussion. They then put onto that equipment map, of which there were 4, and all of them had a consistent theme in that it was a product related to that training scenario. They could then share that, discuss, and then visually place, and then replace, if they weren't happy with it, those photographs. So at the end of that session, the feedback session, after the practical, it was their piece of work. I also wanted to make my research robust and not just have a visual record for my data collection set. I wanted to use analysis of narrative. So therefore, the equipment map provided that process. It provided them with the opportunity to write short sentences about their experience, how they felt about handling that particular sling, how they felt about being demonstrated on the safety of lowering a mast for a hoist, for example, in the event of an emergency situation. So the narrative text was key. And how I looked at that in terms of analysing it, I used Gillian Rose's methodological framework. It's a critical methodological framework that I used to adopt a process where I looked at each photograph that was taken by the participants and analysed it. And as you can see from that centre section, there are 4 sites relevant to this particular framework. The site of production. There's also the site of audiencing. The site of the image itself. And the site of orientation. And each of those elements I analysed against the narrative text to start to bring together some themes, some understanding of what the participants were seeing from that experience. The equipment map was a distinctive approach to use, and a process of reflection was also developed through the feedback session, and the written text was then analysed. This required a very different approach, and for this I used Keats, 2009. where multiple text can be used in narrative research to actually understand the basis for some of their thoughts and feelings. And this actually allowed a recognition and a true, accurate record and interpretation of findings. And after many hours, many months of pulling together all of this, I wanted to see actually what the common themes were starting to develop. So this slide here takes a very small snapshot of the some 50,000 word document that I eventually put together. But I think it's key to explain to you as an audience who will appreciate the understanding of using equipment, some of these findings. So I was looking at the social phenomena being investigated, and what I could see from this was a very visual interpretation of the training in theory applied to practice. I saw that there were key recurring themes on items of equipment. Interestingly, such things as brakes, foot pedals, knee supports, sling holders. There was a collective cluster of narrative and photographs dedicated on equipment. But that was interlinked with safety. And this, to me, was much of an eye-opener and an acknowledgement that our training is not far off the mark. The hidden surprises, the understanding of safety, that in using that equipment, the participants were acknowledging about correct positioning, the adjustments, the requirements for reassurance. And if you remember, I recalled the Indian study, where actually the empathy or the communication with patients was found to be negligible. This was high amongst the healthcare support workers' priority. And I believe that was because they were actually allowed to become the patient. For a very short period of time, they absorbed themselves in that role of patient, being hoisted, being transferred, being turned. And they understood in some part what that experience was. And that came through that narrative and through the photographs. It was also an opportunity to actually understand some of the other elements that was perhaps upmost to them. The feeling of being comfortable in a learning environment. The feeling that they were not being challenged, but they could express when they felt, I didn't quite understand that. Let's try it again. The feeling of enjoyment. And I think today, when we've shared this conference, that buzz, that feeling of gathering, and the feeling that actually we can talk to people and say, well, let's try this method, or, yes, I didn't quite get that, but now I do. And that constant reassurance came out through the narrative and also the photographic images that were taken. One of the many elements or the themes that pulled this all together was actually the hands-on approach to learning. It can't be taken away. I do understand and I do see the future for technology, for virtual learning, for e-learning, but we must not get away from the fact that the practical hands-on is an essential ingredient to how we learn, and particularly for our healthcare support workers. No research goes without considering ethical considerations, and this was the foremost in my mind: the protection of my participants, also acknowledging the university requirements, the trust governance requirements, and accountability. And that was fundamental. I had to ensure scientific soundness. I had to ensure that many key stakeholders were engaged in this process. And I also had to look at confidentiality and how all the documentation that was made available to me would be stored in appropriate data and actually for future use could it be recalled with the permission of all the participants. And interesting, you will notice that from the slides I have shown used by the participants, they actually engaged in permissions with me to share the faces and the expressions and the narrative. It was their words, their faces, their voices. And this was all achieved through prior communication and support. So my contribution to knowledge, and I recognise in this audience today there are many learned colleagues with vast experiences, and I wanted to provide a different alternative, a valuable insight into the delivery of training. I wanted to identify a tool that we are using out there in pressure area research, visual research methods that could be adopted and used for future research in manual handling. But what was upmost in my mind was that actually it raises the profile of equipment safety, and that actually the photographs used in this particular research, there was an emphasis highlighted in the findings. So what next? I believe that it should be recognised exclusively patient handling and manual handling as a core skill. And that should be continued at a very high level. I believe that there is a need to look at competency-based training programmes of a consistent and actually but a flexible approach. And I know that Pam yesterday referred to the HOP7, and actually to focus on a patient-based approach and incorporating that with competence is key. Many of you will appreciate protected time, and I think this is actually fundamental. We actually now have to reflect that many of our hospitals are going through third waves, indeed our trust are at the moment, and we are fighting to protect our healthcare's time out for training. And this is a worrying concern to me. But also the classroom environment, as I've mentioned previously, and I believe that we should actually still have a higher level engagement with our stakeholders, tissue viability, and other elements of professional development to ensure that we have a clinical skills environment that facilitates this learning approach. And as I put there, yes, we do need this to be supported. We need clinical educators and our ergo coaches and our key trainers and the systems that we have in our trusts to support us in a very fundamental training programme. I recognise that as this research, it is limited. It is a small sample. It was not field tested prior to its actual development or its actual taking place. But I recognise too that it could have value if a longitudinal research took place, so over time. So these methods could be used over time from the initial concept of an induction programme and then followed up in the workplace to see actually is the training and that enthusiasm and the perceptions of undertaking this type of training still active by those healthcares a year on down the line. Because we lose so many out into the wider sort of echelons of the divisions that we don't necessarily capture within those early stages. So is it still relevant? How? That's the important question. And I've been listening to many people throughout these past 2 days. We've got to look at the development of learning modules. Yes, I understand that, and at the very need to maintain, and this is why we need our valuable standards such as HOP7 to drive that. But we also need to understand the support that can be given by our clinical educators, ergo coaches, tissue viabilities, and such like. It needs to be discussed at trust meetings, and this is my big drive at the moment, whether large or small, whether community-based, but it needs to be a variety. It needs to be engagement with medical devices, clinical engineering teams who manage in some trusts the procurement processes for our lifting devices. The trust health and safety committees, it shouldn't just be an add-on at the end of the agenda. Training and understanding its context is not just a key performance indicator, a 62% score. We have to encourage our executive teams to share in their meetings the importance of learning patient handling. And also through our learning and organisational developments, which I know are becoming a very niche group because obviously resources are cutting back in many areas. But we do need to have these discussions, and we do need to start from a basic premise. And I keep on about healthcare support workers because they are very precious. I appreciate there are many clinical and physiotherapists and advanced practitioners, but we do need to understand our workforce and all the training that that entails. And as I've said there, I think it is more than a standing item agenda, and I think we need to have it on our trust risk registers to be reviewed by the higher boards. I've included a reflection, and part of my process of my doctorate was that I had to undertake 4 documents, each representing 15,000 words. Document 5 was 50,000 words, and document 6 was 30,000. The combination of all this was my work towards my research, but the final document, document 6, is a reflection. And I think, as you can see from the maze there, yes, there were many twists and turns of this experience. The emotions, when I first started in January 2017 at Nottingham Trent, it was a buzz to be a student, to get that experience of going on campus and sharing with my professional colleagues from around the country the enthusiasm of doing a research study. There was anxiety, yes, but enjoyment, and perhaps capturing the feelings of my healthcare support workers when they opened up that package of prints and shared amongst their group the photos that they had taken themselves. The enjoyment on their faces seeing how they engaged with that training. I also feel on my reflection that the levels of interest and the willingness to take part in this research was fundamental. It could have been a massive flop. I appreciated that the use of a disposal camera had many limitations. You know, were the images going to come out? But actually, that was part of it. You know, that's what you take on with a research. But the level of interest that they shared, because I believe that they wanted their voice to be heard. And that was crucial to the reflection and also the experience of my doctoral journey. Investment in time and energy. It does certainly take a huge chunk out, but there are many people that I can thank along this journey. And I will share that I actually paid for this myself. The Trust did support me in attending seminars and workshops, which I did at a weekend. But I wanted to do this because of my passion. And many of you will know that I have been attending conferences, and I believe the National Back Exchange is fundamental to that, but also our careers in nursing and manual handling in particular have changed over many years. I've included in my presentation a roadmap, and it just shows, for those that wish to see it later on, the journey it's taken. Realistically, it can take anything up to 8 years. Crikey. I didn't wish to embark on that length of time, but 4 years will be hopefully my end goal. And lastly, any questions, but I have put together, as I promised, an acknowledgement piece there and also references of perhaps some poignant authors that I've alluded to in my research. So I'm conscious I'm a little bit ahead of my time, but I have brought my equipment maps. If anybody wishes to discuss anything during the break, I'm happy to share. But fundamentally, thank you for listening.
You can't go yet.
Oh.
Thank you very much. That was fascinating seeing that journey into that work. So, do we have any questions? Is anybody considering a similar journey, or maybe maybe has been part of somebody else's research project?
Yeah.
Yep. So let's have some questions. Do we have a roving mic anywhere? A roving mic? Yes, thank you. Any questions to Philippa? Yes, somebody at the front here.
Sorry.
It's coming.
How did you
Um,
how
yeah.
how did you decide on 11 participants?
Okay, so the purposeful sampling procedure incorporated that criteria, and it was based on those attending an induction process. So on average, we would actually have about 20, but the courses varied depending on those that were successful at interview. So out of that particular training program, for that particular month, that particular day, 11 were available and included in the criteria. So I acknowledge it was small, but actually with the ratio of trainer, which I then had to reflect upon, it provided an engagement. Anything more than that wouldn't have been reflective of safe practice. So 11 was quite an interesting number. But actually, as the study developed, the number didn't seem to matter, if that makes sense. What mattered was the data that was coming out of it and the richness of that, and the participation in those groups. So when they actually had a feedback session on the second day, when they opened up those packets of photographic images, they formed their groups, they discussed and had quite an intuitive way of sharing that information. And the final equipment maps is their own piece of work. So it was part of that sampling procedure. It was very purposely done.
Any more questions? Right.
I expected one from
Thanks, Philippa. I think the structure of your report and your projects, and I think taking a look at qualitative data from a learned experience is it's a more familiarly trodden path.
Yes.
I just had a thought as you went through the process. Do you think that engagement that those participants got by having to take photographs and having to relive, do you think they would have remembered it better?
I believe that recap, that re-evaluation, enabled that process. So on the day of the training, they lived that phenomenon, they lived that experience. But perhaps we don't give them the opportunity to reflect on that. A tick box checklist of an evaluation, I don't believe fills the gap.
No.
So allowing that second bite at the cherry, so to speak, yes, gave them, through the images, that chance. You know how we see it on a photograph when I've been fortunate enough to do cycling in South Africa. And only the other day, I thought, oh, I do miss my cycling. I do miss South Africa. And I looked and I recalled the sights, the smell, and the sounds that evoked by those images. So it is a reflection. And I think that was key in the engagement of my participants and the freedom to actually script narrative. And I haven't changed any of the wording. So my final thesis document is transcribed with their sentences, the grammar, the text, the inverted commas, the boldness of the arrows and where it directs them to it. And the enthusiasm, I was just blown away by it.
It just made a real,
Yeah.
it really
Impact.
gave resonance about this idea of,
Yeah.
I'm on the other side of the process as well, you
Yeah.
appreciate.
Yeah.
This idea about engagement, this idea about learning, this idea about understanding and application of the knowledge, you're
Yes.
exactly right.
Yeah.
We deliver it, we don't know whether they've engaged with it. We don't know. You know, our bosses say, measure their engagement, to which
Yes.
everybody says, well, how you tell me how to do it and I'm all over it.
Yeah.
You know,
Yeah.
but that sort of process, you know,
Yeah.
and maybe there's a better opportunity for reflection and learning and,
Yeah.
you know, and reviewing what's gone on.
Yeah.
And maybe that's the important section of the training as much as it is anything else. I thought that, you know, that really came out
Thank you.
in the process there. And very good luck in your Viva.
Thank you.
Anybody else going to ask something?
Thank you for the presentation. Were your 11 people new to care, or were they all experienced and already done it before?
So in applying for the healthcare position, they can come with new sort of experience from care homes. They can come with experience working in trusts. But the actual sample that I had were brand new. And I do believe that that actually was pivotal in some of the findings because they had that freedom. However, they were also very knowledgeable. Does that sound contradictory? I think it's because when they saw the equipment, they saw it being used, they actually incorporated themselves into the role of being a patient. They felt what it was like to be slinged, put in a sling and then hoisted. And I know that many of you will remember that first experience. You know, I did with trepidation. And some of the images, when you have a look, you can see it in my study, you know, you can almost see the whites of their fingers grabbing hold of the frame to support, you know, am I going to fall out? Am I going to fall out? Is this sling too tight? You know, have you got me safely in it? So in answer to your question, they were new. And I think that's important to appreciate. But irrespective, the knowledge gained, I think in terms of training, you have to start from a level playing field. It's right to acknowledge those that have had past experiences, but it's the wrong way necessarily to approach that training. I think you have to look at it from the standards, you have to look at it with a fresh pair of eyes and say, what does our training actually give? How can we deliver the best training that provides the most receptive response so that when they leave that classroom after one day manual handling, we did have 2 days as an induction process, but it was whittled down, that they go onto that ward and actually say, I remember this. I remember how fundamentally it was important to insert that slide correctly, to avoid friction and shearing forces. And if I may say, when I was training in the 1980s, we had a tutor that actually went in for 4 days, nursing care technique. We were actually instructed on the principles of hygiene over a 4-day period. That was the intensity of the level of that care that was being, you know, offered in terms of training. I do worry whether we still have that. It's not without the passion of all our colleagues here today, but I think we're inclined to think about the pressures upon us to make shortcuts. I'll leave you with that thought.
Anybody else going to ask something? Yes. It's coming.
Thanks. Thanks very much for the presentation. I'm just being curious, really, a bit nosy. I noticed you specifically described the trainers as health and safety trainers.
Correct.
So were they health and safety trainers doing a bit of manual handling, or were they manual handling specialists?
So they were health and safety trainers. So our trust has a protocol of training that allows health and safety trainers who are trained to deliver patient handling through an ergo coach system. So I made that reference because obviously that was important to share in my study, but I acknowledged that they had the competencies to deliver that training on the equipment and the techniques through a recognised standard and qualification.
Okay. That was pretty inspiring, I think, and I think those sessions with the carers engaging and doing that must have been tremendous. I'm not sure who was luckier to attend that session, yourself or the delegates, but I found that fascinating.
Thank you.
So perhaps before we all toss her off for perhaps a recovering cup of tea or coffee, perhaps you put your hands together and thank Philippa for her session.